The endoscopic approach to the brow, we don't use endoscopes, but so I use 5 incisions. I know you can do it with 4, but I find it's much more difficult to get down to this area. So 1 central incision here, okay, and then I know there are a lot of different ways to take care of the hair, but what I like to do is just use these little brown paper tapes. One of the reasons is they come off a lot easier at the end of the case. So just a little brown paper tape. There we go. There's one. Okay, and she has longer hair, so we have a little challenge here. Okay, and here's the second one. And then the marking her laterally, which is where we don't want to do a lot of central lift. We do want to do some. But if you just go right to the lateral tail of the brow, right in here, okay, so right about the lateral, maybe 1/5 of the brow, make another incision right here. And again, just coming, I go right to hairline. Now she doesn't have a short or a long forehead. That's probably 6 centimeters, and that's about good. If it's longer, it almost doesn't matter. Okay, so there, a couple centimeters. And then the incision over here, I go about, if you look at all of the studies, you'll never injure the temporal branch of the facial nerve if you're behind the hairline. So go just about 1 centimeter. That's where I like that incision. If you get too far posteriorly, you're more likely to get into the superficial branch of the temporal artery, and that is always, not desirable. It's not the end of the world, but it makes life a little difficult. So I'm 1 centimeter behind here, and that's my marking, and then I will go maybe a couple, 3 centimeters right back here. And that allows us to, not being too far behind, if we decide to incorporate the mid-face, we are closer to that. Again, the further back you get them to go, the more difficult it is. So we have some marking, 0.5% marking and 1% lidocaine with epinephrine. And I like that because the incidence of post-op nausea and vomiting is high if you don't. And so it never really made a lot of sense to me to mask the forehead. I mean, what are we really accomplishing? In fact, that would limit lifting. So what I do is I inject, because we do have the epi in here, I inject my incisions, okay, just a little bit in each one, because obviously we don't want, we want some hemostasis there, so I inject the incisions. I'm going to go ahead and do that. And then, just where we're going to release the periosteum around the orbital rims. And to me, again, if I'm thinking about it, what's going to give the best in the way of pain control, or what's going to cause the most discomfort, it's releasing that. So here's what I do. I go about 1 centimeter. Now here's the supratrochlear vessel, should be right about here, right about here. So I come just a little medial to that, and this is all I do. I make about 1 centimeter apart, walk down around the orbital rim. Okay. Now if I'm doing the mid-face, I'm not in this particular patient, I will even do the arch too, but I'm going to go ahead and just show you. You can feel the arch, you just put a little bit around the arch, and then we come around and we do the orbital rim on the left side. Typically, we're at about 6-7 cc's, but usually I'll go somewhere around 8 or 9 cc's to do all of my injection. And so that's basically injection. Again, it doesn't make sense when I've heard people to mask the forehead. It doesn't make any sense at all to me. And this is a limited amount of local, but yet sufficient amount of local. Even though this is done under general, we don't want the patient to be nauseous or vomiting afterwards. So a couple little tricks. I mean, I use this wet lap pad back here, and that really helps soak up some of the blood, so that it doesn't make a mess out of our hair. This patient in particular has thick, long hair, so that's important. So okay, ready? All right, so 15. So these are 2 wet sponges, and we know we need to release this here centrally. So I'll make my incision here, just about a couple centimeters, wide doubles. So with your right hand, reach over here, and the left hand, reach over here. What I do here is I just cauterize, being very careful not to obviously injure the hair follicles, and having done this for years now, I can tell you, as long as you're careful here, you're not going to have an issue. And then what I do is I just get through the periosteum, all right, small sharp dissector, and this is, I got this, you told this, I got this one. Yep. And so I'm just going to, so this is a small ebonized, this is made by Richards, and it doesn't matter what you use for this as far as what company. Thank you, Jigger. Appreciate that. So I just kind of do this. You know, we used to put the scopes in for all this stuff, but, and as far back, we only go back maybe 4 to 6 centimeters. There's no reason to go any further than that back. In fact, if you go any further, you get into the, you know, occipital vessels. But bottom line is, what you want is you want to redistribute this tissue. So I take this one first, and we know that it's safe to go right down here on the root of the nose. And we know that we're not going to injure anything if we come down here. Okay. Now, from your paramedian forehead flap, we see these supratrochlear vessels. So I'm lifting here, and then laterally, I'm going to come right down and take the periosteum off the orbital rim, right? And we've actually done this with the scope and watched in there, and you can stretch the nerve, but you're not going to injure or transect it. And in many years of doing this, I've never had anyone with permanent numbness. Paramedian incision here, or off midline, just to the lateral brow, and this ends up being about 2 to 3 centimeters as well. Now, the difference here is we're going to make a little bone tunnel in this, okay? Okay, grab that, and then actually set it down like this. There we go. Bovie, dry sponge, please. Now, I typically wear a headlight with this to see a little bit better, but I'm not going to do it today just because it makes a hot spot on the video and harder to see. I try to do very little and I'm careful of the hair follicles. This looks pretty good actually. Okay, so what I'll do is I'll drill my little bone tunnel, and just pay attention to where this is located. Okay, the bone tunnel. Just want to make sure that hemostasis. Okay, is right in the center here. And you'll see when we move this back, the bone tunnel is going to be much more anterior. Okay, so I'll take this, and this is a 6 millimeter recessed bit. And there's actually, Jonathan Sykes has a little tool that you can use to help as a guide. But you want this recessed because obviously you want it stopped, you don't want to be able to go too deep with it. And I just hand drill it, okay? And what you do is you start slowly, you register the spot, and then obviously be very careful of the hair. And I say that because you can easily grab the hair and you know, have some hair loss in that spot. So that's not cool. So but it's very easy to do if you're not paying attention. And then I just drill my bone tunnel on an angle right here. And the most important thing with this is to push forward with the drill and let the drill do the work and not to torque the drill. The most common mistake I see with the fellows is torquing the drill, and you can break the bit. Now you can use other, and I don't want to get into trade names, but there are other little devices you can use to anchor this. Quite frankly, many of them have a high profile, and you can feel them, and they're expensive as hell. So what I do is just test this to make sure that my drill works, and you can see there's the suture sticking out, and that suture is what we're going to use to suspend the brow. You know, you're talking about a $15 suture compared to one of these expensive devices that has a high profile, and actually, quite frankly, we've seen more problems with. So this has worked for many years. We make this one typically about 3 centimeters in length. All right, and this location is much less likely to injure one of the branches of the superficial temporal artery. Okay, take this here, okay, and I'll take the other one. Bovie, please. All right, hold this one, Jigger. And so again, if you see a vessel in here that's significant, this is the area that I will identify them and tie them off. You cannot Bovie your way out of it, and they end up making a mess. Steven, scissors, please. In just a second. Okay. All right. So what I want to do is go right down to temporal fascia. There's a vessel right there. Okay, we're going to tie that one off. So there was a little vessel we had to sew. So once I'm through that, I just clean it up, and then I'm right down to the temporalis muscle, or the superficial layer of the deep temporal fascia. And what I use is this blunt dissector posteriorly, and I can literally, I got this one, Jigger, you hold that one. I can literally just elevate in that plane. There's a bloodless plane posteriorly, and it's so easy to do, okay? So we've done our blunt dissection and lifted the temporal parietal fascia right up off the temporalis muscle, okay? Going back about 4 to 6 centimeters and stopped right at the conjoined tendon. We're gonna pop through that in a moment. Then what I like to do is use a small sharp dissector. And again, it's gonna be hard to show this a little bit, but because you won't be able to see in here. But I like this because I can cut through these fibers. And I intentionally go right down here in the preauricular area. Now I am going to have to flip my headlight on, so unfortunately you may or may not be able to see this because it sometimes creates a hot spot. But with this opened up, Sandy, can I please have the converse? I use my converse retractor, like this, and a headlight, and I can do basically, let's see, bipolar please. Try to do a little vessel there. Bayonet sponge. Sometimes you'll get these little vessels that but these you can actually bipolar. Go ahead, Cuddle. Now, Cortical has shown that you don't want to be bipolaring up high on the temporal parietal fascia. So I bipolar right down on the temporalis muscle. Okay, next please. And so you can bipolar and just cut these, and they do really well. Okay, small sharp dissector again. And let me have the bayonet sponge, just clean it up. And this is pretty much an avascular plane, other than those few vessels that come from deep to superficial. But other than that, it's pretty avascular. Okay, I'll take the small sharp dissection. And then I take my dissection all the way out, basically to the lateral canthus. And I'm trying to show that. And you'll start, you can get into these sentinel vessels. Here, we got one right here. Here's one of those sentinel vessels, you can see it. And they're rather large, and it's just lateral to the lateral canthus. Pretty predictable, you see in a lot of patients. What I try to do is, I used to bipolar them, I no longer do. Kind of like if you're doing a bilateral neck, you know, if you can preserve some of the venous flow, I think you're going to help with less edema in the forehead area. So I just isolate that and leave it alone. Then what we do is we come superiorly here, and we actually pop through into our central cavity. This is the conjoined tendon. Okay. Now we've created a big optical cavity with a release, and all we have to do is suspend that back up. So now, you know, once we know we have a complete release, we come back to our where our little drill hole, and she's oozing from the wound edge, and that'll be obviously taken care of once we wide double. Yeah. And then what I do is I come anteriorly with my wide double, and I take the biggest bite that I can, okay? And what I'm looking for is to grab a big cuff of periosteum and soft tissue. And again, I don't have my headlight on because I'm trying to, but I normally do it with a headlight. You can see a little better, but I want to be able to capture some of it with the video. Okay, so here's my suture. And then, hold this patch here. You see where, remember when we drilled initially, the drill was in the middle incision. That's because we moved all this tissue back. And basically I pull the lateral brow as high as I can in that area. Surgeon's not. Okay. And then we just close that with a stapler. Superficial layer of deep temporal fascia. Now again, you don't want to grab a lot of temporalis muscle because patients are going to complain of some trismus. So it's a nice big bite here. And then anteriorly what we're doing is to just get a nice big bite of the temporal parietal fascia, which is right here. And again, we're a centimeter back, so we're not going to injure the nerve. That's an important part. Okay, nice big bite of the temporal parietal fascia. And again, normally I do this with a headlight. I'm trying to make it a little bit better for video so that you can see it without the hot spot. And there's the temporal parietal fascia, a nice big bite of that. And that allows us to get this temporal complex back up where it belongs. Patients do complain of a little bit of trismus, but again, providing you don't take too much of the temporalis muscle, it's transient and really typically lasts a few days.